Okay, hi everybody. Hi again. My name is Mark Masulo. For those who don't know me, I'm a board member and I am the secretary of Clusterbusters. So happy to be here today and glad that you're all here. Our next presentation is a sequence of 15-minute presentations regarding research. So our person who was going to be presenting on the Bowl 148 is not here. So we're trying to locate him, and in his absence, we're going to move forward. Mark Burish and Staurt Pearson will be presenting on the cluster headache questionnaire update. And Mark is a neurologist with an MD and PhD. His research interests surround epidemiology and basic circadian mechanisms. So along with Staurt, who is also a researcher, and Staurt, I don't have your biography, but I know a little bit about you. I know that you work closely with Larry and that you have an interest in cluster headache, and you've been working with our community for a number of years now. So feel free to add to your resume if you want to. So with that said, Mark and Staurt, please feel free to go ahead.
Thanks. Staurt, do you want to share your screen or do you want me to share it and you can kind of just select the next slide? How would you prefer to do it?
I want to, if you're okay to advance the slides for the first 5, that's fine for me.
Sure, sounds good. Make sure this works. There we go. Can everyone see that?
Yeah, I think we're
okay.
I think we're good.
Perfect. Let me introduce Staurt, sorry, real quick. So Staurt is I guess he's now finished his master's. He's a PhD student at the University of West Georgia in psychology. Former military, worked a lot with kind of psychological factors and things, obviously as a psychiatrist, and has a special interest in that in the military population, if I'm right, Staurt.
Close enough.
Okay.
Well, hi everybody. Mark and I are going to be talking today about the cluster headache questionnaire, which many of you are, I'm assuming many of you are familiar with at least. This is a project that we conceived of back in 2016, and it went for 2 years until 2018. And so Mark and I are going to be talking about that a little bit today. Just to mention a little bit of some of the support for our project. Clusterbusters obviously has been a major and primary advocate for us, but also Autonomic Technologies has been supporting our project since the beginning. So just to give you a little bit of an idea, a quick overview of what the study looked like. Our study was an online questionnaire. It was 152 questions. There were 5 separate sections, and the actual survey itself was reactive or adaptive. In other words, so as you took the survey, it presented certain questions based on how you responded. And this, for example, is just a panel on what it would have looked like if you had taken it online. And today we're going to talk a little bit about some of the findings that we've gathered. So overall, we ended up with 3,251 total respondents. But what I'm going to talk through here is how we've gotten down to sort of our study cohort, just the number 1604 that you see at the bottom. So if you'll advance, Mark. So the first thing we did in terms of whittling down our survey respondents was to filter by people who completed 90% of our survey. And then from there, you can see that in the actual survey, we had sort of questions that were designed to increase our confidence in the results that we got. So one of those questions was whether or not a respondent was diagnosed by an MD. And then, of course, we've got age over 18. And one of the other things that we did with the survey is we actually translated it into 10 different versions using 10 different languages using Google Translate. So we, for further clarity and confidence, we filtered out specifically for the English version. And then from here, what you're looking at is the the criteria for diagnosis of cluster headache based on the International Classification of Headache Disorders, I believe from the 2010 or the 10th version. Mark can confirm. For criterion A, obviously at least 5 attacks. B1, we have severe pain, which we were calling 7 to 10 on our 10-point scale. Unilateral, one side of the head, and then pain lasting anywhere from between 15 to 180 minutes. And then for criteria C, any sort of autonomic or restlessness type feature. And then our final was the frequency at the peak was 0.5 to 8 times per day. And that's how we got from our overall cohort result, which was 3,251, and whittled down to 1,604, which is what we focused on for the purposes of our actual statistical analysis. So of that 1,604, we've got 56 countries represented, and see, we got 7 countries from North America, 4 from South America, 30 from Europe, 4 from Africa, 9 from Asia, and 2 from Australia and the Pacific Islands. So we've got a pretty robust representation from around the planet. And I think from here I'll lateral over to Mark for the
Thanks, Stuart. So some of this is a little bit of, how laws and sausage are made a little bit as far as how we whittle it down and how we're doing this, but we have to do this in a very scientific and manageable approach. And the oxygen and Medicare, I'm actually going to come back to this because I'm giving another talk in a little bit, and right after that is the advocacy stuff. So it might be better to actually go over this oxygen data right before we go into the advocacy. The quick version of this is to show you that if you're looking at red being completely ineffective and kind of different codes of blue being some level of effective, the ones with the least amount of ineffectiveness were the triptans and the oxygen. Those were kind of the 2 most effective things if you kind of look overall. Caffeine was, you'll see no red, but there's only 2 people in this category. This is only people 65 and older. So these were far and away the most effective. And then if you look at side effects, kind of all of them, if you're just looking at these 2, oxygen has less side effects than the triptans. And I'll go over this in a little bit more detail in a second, but the kind of takeaway from this is looking as a group, not as you individually, but as people as a group, oxygen is the best, and that includes patients over 65. It's got the best combination of high effectiveness, low side effects. But again, I'll come back to that with the advocacy stuff. This, I feel like we've beaten to death a little bit during this presentation, during this conference, which is great. We're preaching to the choir on this stuff, and as far as how painful cluster headache is, and everything else is less painful. The reason we keep bringing this up is not to tell you guys, everybody here knows this already, it's to tell everybody else. This hasn't been officially scientifically shown before, just kind of anecdotal people say it's really painful. If you can tell people who have never heard of cluster headache, well, what is this disease? Oh, it's maybe the most painful thing a human being can go through. It's way more painful than kidney stones, pancreatitis, and childbirth. That grabs people's attention. And so getting this out just from an educational level is really, really important. And then someone asked in one of the chats, could we use this to see if it correlates with other things, which is a great idea. We did not see that it correlated with treatments. For example, if you had more painful headaches, oxygen worked better, or verapamil worked better, anything like that. We looked for that, but we didn't find it, unfortunately. So the rest of this data is new stuff. This stuff we haven't published, we haven't really talked much about, and I just kind of want to show you kind of updates from this. So one is what the best medication is for cluster headache on the preventive side of things. Again, red is completely ineffective and blue is varying levels of effectiveness. And then on this side is kind of side effects or complications. It does appear that the best ones over here are steroids and calcium channel blockers. That's mainly verapamil, as opposed to some of the other things like methagonovine or methasergide, which Dr. Silverstein talked about this morning, anticonvulsants like Topamax or lithium, testosterone, and beta blockers like propranolol, which we really don't use that much. And then on side effects, again, green is kind of less side effects, red is more side effects. The steroids and calcium channel blockers are kind of similar to a lot of the other ones as far as side effects go. Calcium channel blockers may be a little bit better. But this is, again, not, this kind of goes after what we've been using with for a lot of patients on the clinical side already. This is not asking about psilocybin, for example, and a few other things. This is looking at things that are prescribed right now. There are some things that are more effective in episodic cluster headache than chronic. And so we ask patients, we have this whole category of people who have chronic, whole category of people who have episodic. We kind of compared the effectiveness between the two. Things that are more effective in episodic appear to be oxygen, calcium channel blockers, and beta blockers. And then there's some data from other studies, not ours, that the Emgality injectable medication that you give yourself once a month and the stimulator you put on the neck called GammaCore are also more effective in episodic. This doesn't mean they shouldn't be tried in people with chronic, and it might not work for one individual person. There was actually this month a paper that came out saying that we should really try this more in people who have chronic just to see if it works, because it does work in some people. But that was some data. And then there's a whole bunch of medications that seem to have equal effectiveness. The triptans and ergotamines and DHE, which Dr. Silverstein talked about this morning. All these other medications seem to be equally effective in chronic and episodic cluster headache. And this is interesting, I think, from a research perspective, when you're looking at what are the new things we should start looking at. What are things that might differ between chronic and episodic cluster headache? A couple other things here. Dr. Gottschalk mentioned this earlier, but based on our data in this study and on two papers that were published this year, one was ours and one was a group in London, it looks like about 6 to 10 patients, cluster headache patients, have a family member with cluster headache. Now, that means that 90 to 94% don't. Now, if you're looking at, does this mean that my child has a 6 to 10% chance getting it? Not necessarily. This means that there's someone in your family has a 6 to 10% chance of getting cluster headache. But with these 3 articles kind of coming out this year and looking over all data, I think this is we're pretty confident that this really is the rate of cluster headache. So there's a genetic link, and it's not in everybody, but it's in a small group of people. We think probably what's going on is there's some combination of things. It's probably you need a couple of genes plus some environmental trigger. Maybe it's smoking, because as a couple of people have commented already that they always have to get people out from the smoke break. There's a high incidence of tobacco smoking in patients with cluster headache. Maybe it's not, maybe it's some other exposure that we don't know of, because obviously plenty of people smoke and never get cluster headaches. But maybe there's a combination of 3 or 4 hits that you kind of all need to get all of them, and then you develop cluster headache. But we did find in our study that if you had a family history of cluster headache, you were more likely to get headaches around your early 20s. If you had no family history, you're more likely to get headaches in your later 20s. This is not when you were diagnosed, this is when you actually got the headaches. So our conclusion is that the patients with a family history actually might get it younger. So there may be actually some genetic, some interesting genetic thing there.
Mark, would you, I apologize for interrupting. I didn't ask you before we got started. Do you want to take questions during your?
Happy to, although I know I'm already running up against the time here.
Well, we don't have our first presenter yet,
gotcha.
So you can have time. So Eric Cohen is asking if anything was more effective for chronics than episodic.
Nothing, good question. Nothing that we found was more effective in chronic. Now, we didn't look at psilocybin and things like that, but of the prescribed things, we didn't find anything. I don't want to leave out the patients who get diagnosed older. So we also looked at that who get onset when you're older. So some people don't get their headaches don't get cluster headache until they're in their 50s, 60s, even 70s. They live, their early adulthood without ever getting a cluster headache. There doesn't seem to be a difference in these people. So is there something different about, people who get a older age? So there doesn't seem to be any difference, male or female, the level of pain, the number of attacks you have a day, any of the restlessness or watering eye or runny nose. There doesn't seem to be a lot of difference for patients who get it when they're older. And most importantly, the effectiveness of medicine seems to be about the same. So again, patients who get it when they're older seem to be about the same from everybody else. There's nothing special. I don't mean that you personally are not special, but in general, there's nothing special about this group of patients. They should be treated the same way. Males versus females. So everybody knows, it's heard a couple times that it's more common in men than women, although it's probably not as high as we think. There's no difference as far as how long the headaches last, any of these restlessness things, except for some people get this kind of feeling of fullness, like their ear is underwater. That's a little more common in women, but everything else is the same. And again, most importantly, the medications seem to be about the same. There are a couple of small differences. Pain level seems to be slightly higher in women. There's a lot of possible reasons for that. I'm not going to go into them because we have no data for why. We just have it. We just have the information. The number of attacks. So women tend to have a few more attacks per day, and women tend to have a little bit more nausea and vomiting. But in general, men and women are more similar than different as far as cluster headaches go.
Mark?
And then, yeah.
Elizabeth Linden is asking if she's wondering if she might have missed this. I don't think so. I don't think this was addressed. Wondering about the efficacy of CPAP, using a CPAP machine in relationship to cluster headache.
Yeah, it's a good point. It is an important thing. We didn't ask about it in this study, but what she's talking about, for those who don't know, that there's some data that CPAP, which is that big device people use for sleep apnea, that it's called continuous positive airway pressure. So essentially blowing air back at you when you sleep to keep your airways open and not collapse with sleep apnea. There's some data that is helpful for cluster headache. Most of the data, my understanding, is for people who actually have sleep apnea. I don't know if anyone's ever done a study for people without, but we didn't ask about that in the study, so I don't know.
Okay. Before you go on, Brian McGeaney is wondering about propranolol. Am I pronouncing that correctly?
Yeah, propranolol.
It's more responsive in episodics, and what you might be able to tell us about its use in cluster.
Yeah, so let me go back to that. So the beta blockers might be a little bit more effective in episodic than chronic. However, and one of the things Dr. McGee would point out, we don't use propranolol too much, really much at all, for cluster headache. This does get used for migraine a lot, so people who get confused or a doctor who misdiagnoses it with migraine might give you propranolol. It's typically quite ineffective for most people. Okay. But that being said, every now and then it does work, and it tends to work a little bit more in episodic. So this is not something that I would recommend to people to go out and ask your doctor for propranolol, because it tends to be one of the less effective things. Just going back to this list, it is, if you can see here, it is the bottom of the list. Almost everybody found it completely ineffective. That's beta blockers, and propranolol is the most commonly used one. So I just have one last slide left, which is what we're doing with this data. So a lot of people say you've got this huge, enormous data set. 1,604 people is the largest data set ever collected for cluster headache as far as we know. And so we feel like we have a responsibility as far as what we're going to do with this. We have three kind of prongs to this. One is advocacy, and we'll get into that a little bit later about using this for oxygen and Medicare and things like that. The second is education, not for this group. This group already knows all this stuff, but this is the pain level and things like that, about letting people who have never heard of this disease, including doctors, know what this is, how bad it is, and actually quantifying that. Not just telling them stories about 2 or 3 patients, which are very powerful at a personal level, but not at a scientific level. Now we're trying to turn that kind of powerful thing into a more of a scientific report. And the last is driving future research. So one of the things when you have a huge data set like this is you can start to look for subgroups of people. Stuart has a lot of experience with statistics and things like that, and I know we've been talking about that a bit, but you can start to look at, do patients who respond to oxygen and are female and are over the age of 50, does that group of people respond more to oxygen or more to triptans? And so you can start to get more individual medicine. This is something that's obviously important to people here. Rajir from Nobism, who was presenting that earlier, is looking at individualized or personalized data. Same idea here. Can we start to look at subgroups of people that might respond one way or the other, or find some interesting subgroup that we can focus on to, the genetic group would be really interesting. If there's a group of the family history and we can find a gene that gives us a starting point. Well, what does that gene do, and how does that cause cluster headache? And so that's kind of what we're talking about with this research. So I know that's my time. I've got a little bit more I'll talk about later at the other presentation, but on behalf of Stuart, Larry, Bob Shapiro is going to talk later, and myself, thank you guys very much.
Thank you so much. That study is just such a meaningful contribution to the existing literature. Before we go, Mark or Stuart, there's another question. Bernie Katzer asks if there's an age when a cluster headache may tend to alleviate, or with women, does menopause impact it? Any thoughts?
I'll start. Stuart, if you want to add something, let me know. The cluster headaches do tend to get better in general as you get older, but we don't have any data for any individual patient about if yours will get better or not. But they do sometimes go away with age. They sometimes ease off with age, but not always. So some people, they get worse. So as far as menopause goes, we do see that from migraine for sure, but we don't see that as much for cluster headache right around that time. I'm sure it does happen for people, and Dr. McGeaney or others can weigh in if they've heard other things, but I have not heard anything specifically about kind of your late 40s, early 50s, and headaches kind of changing a big time at around that time.
Thank you both. We'll move on to our next presenter in this series. Dr. Fiona Dunbar will be talking about a SUNA survey related to SUNCT and SUNA. She's a physician with an extensive background in the pharmaceutical industry. She's contributed to drug development across a range of therapeutic areas, including neurosciences. If there's anything else you'd like to add about yourself, Fiona, before you start, please feel free to.
Thank you for the introduction, Mark, and a sincere thank you to Eileen and Bob for inviting me to participate in this conference. It's a real pleasure to be with you this afternoon. So I'm briefly going to share an overview about the survey that we have in SUNCT and SUNA patients that's being conducted by Clusterbusters and the Beckley Foundation. And let me start by sharing how the survey came into being. So about a year ago, I started collaborating with the Beckley Foundation, which is a UK-based think tank that is dedicated to advocating for global drug policy reform and for initiating and supporting research into psychoactive substances. And the foundation is really interested in understanding more about very rare and under-researched headache disorders. And through members of the foundation, I had the privilege of being introduced to Bob, and we decided that we would implement this survey. And we're very fortunate that Dr. Burish, who you just heard from, and Dr. Matheru, who is based in London, are the experts who are providing input into the survey. So SUNCT, let me just try and get this in slideshow mode. SUNCT and SUNA are both short-lasting unilateral neuralgiform headaches, and like cluster headaches, they belong to the TACs. They are even rarer than cluster headaches, and there are very little research that are available, and most of the data is collected from small case series of individual physicians. Now, I had an audience poll question here. Andrew, I wonder if we can put that up just to try and understand if we have anyone who's participating this afternoon who has TAC diagnoses other than cluster headaches. So may I ask you if you'd respond to the question here? We'll just take a minute to do that. Andrew, do we have the responses in?
Yep, they are still rolling in. We'll give it about 20 more seconds or so.
Okay.
All right, looks like they have stopped coming in.
So thank you for that. And as we can see, the majority of participants this afternoon have cluster headaches, and we do have some people who have more than one of the tics. So thank you for sharing that. Bob has told me that over the years, several people with SUNCT and SUNA have reached out to him and have requested to become part of the cluster community because these conditions are so rare that there aren't any dedicated support groups for these patients. So these are the diagnostic criteria for SUNA. The headaches are typically described as very severe, one-sided, and they are very short-lasting, between 1 second up to 10 minutes, and described as single stabs or series of stabs or in a sawtooth pattern. And these headaches can occur up to 100 times or more per day. SUNCT was first described in 1978, and there have been case series since then. There's only been one clinical trial with a pharmaceutical product. And as far as we've been able to ascertain, there are no patient surveys and no published data on the patient lived experience. And this was one of the main reasons why we wanted to go ahead and undertake this survey. So the survey content is based on the extensive experience that ClusterBuster already has with patient surveys, and includes questions on demographics, family history, headache duration and frequency, triggers, and there are many, many triggers for SUNCT and SUNA: touching the face, brushing the hair, eating, chewing. We asked about all the medications that have been tried and the responses obtained, and surgery. We're in the process of crunching through all of the data, so I'm not going to share any of the qualitative results with you this afternoon, but I would like to share with you some high-level observations. And the first one is the response rate. When we started the survey, we had no idea how many responses we would receive, and more than 180 people responded. So a huge thank you to everyone who took the time to give us their feedback. Three things that really jumped out straight away were around the diagnostic criteria, the time to diagnosis, and the medication response. So firstly, with the diagnostic criteria, as we looked at the individual responses, it appeared that several of the people who had given us their feedback had features that seemed more indicative of a cluster headache. And it may be that there is overlap in the diagnosis, some confusion, or it may be, as we saw in the responses to the earlier question, that some people have more than one type of TAC. The time to diagnosis was really distressing to see the feedback. Less than a third of people had their diagnosis within 1 year of onset of symptoms, and more than a third had to wait over 6 years before coming to the correct diagnosis. And in this slide, I've pulled out some of the verbatim responses that we received. And as you'll see in the top right, one person had to wait 25 years of seeing many, many doctors before they got their diagnosis. I thought it was very distressing to see the number of unnecessary invasive procedures that people endured because of misdiagnosis, having teeth pulled, having root canal, having sinus surgery. However, it wasn't all doom and gloom, and if you look at the bottom response, somebody who had a more positive experience, seeing an emergency physician and their neurologist, and able to rapidly get to a diagnosis. In terms of medication response, for each of the drugs that had been tried, we asked if they were not effective, partially effective, moderately effective, or completely effective. And one of the things that really jumped out at me, and it was the same in the survey results that Mark has just presented, the tiny percentage of people who find any therapy as completely effective. And when we looked at all of the medications that are currently included in treatment guidelines that can be tried for SUNCT and SUNA, less than 10% of people gave feedback that they were completely effective, really just underscoring the huge unmet need for more treatments. So what are we doing with the survey? We are going to complete the analysis and hope to be able to publish those. And I hope that maybe if you'll invite me back next year, I'll be able to share the details of those with you. We are doing follow-up interviews, really in-depth interviews with some of the respondents who gave us permission for further content, so that we really can provide more about the lived experience of people with these rare conditions. We started some separate work looking at epidemiology. There are only 2 studies estimating the incidence and the prevalence of this condition, so the number of people who are newly diagnosed and those living with the conditions. So we're exploring databases across different countries to see if there's ways that we can add to that information. And we are trying to evaluate to see if it might be feasible to initiate and support clinical trials in these rare headache conditions. And on that note, I had 2 further poll questions, if I could ask for your feedback related to clinical trials. So first question is, would you be willing to participate in a clinical trial if there was one available for the treatment of TAC? And I know it's a very broad question, but I'm particularly interested in hearing how many people would just give an outright no, that they're not interested in participating in trials. So if you would respond to that, I'd be grateful.
Fiona, while folks are responding to that, there were 2 observations or comments that came in. If you click your chat function, you'll see them, or I can read them to you. Maybe you would address those before you conclude.
I can't get the chat function while the poll question is up.
Okay. Shall I read them to you?
Thank you, Mark. That would be helpful.
Okay, so Karen Mann says, I suspect I have SUNCT in addition to cluster headaches, but can't get any doctor to consider this since they pretty much aren't familiar with SUNCT. And just my own sort of add-on to that is, we all know how hard it is to get diagnosed with cluster headache. So, I mean, SUNCT, yeah.
I think that really underscores why we're trying to do this survey and increase the knowledge. And I mean, I'd be interested to hear what Mark has to say as he sees patients, but it's certainly been described that you can have more than one TAC. Good, so here are the responses in, and that is really encouraging. Then more than 3/4 of people would be willing to consider participating in a clinical trial. So thank you for that. And then the next poll question was a practical one related to clinical trials. So if you were participating in a clinical trial, would you prefer to record the feedback about your headache attacks on a paper diary, via a computer, an iPad, I should have added a phone in there as well, or using a wearable device, and recording things such as the duration, the onset, and the severity of your headache? I'd be very grateful for your feedback about that.
Well, while folks are answering that question, Jessica is noted that her doctors hesitant to diagnose her because of an unclear response to indomethacin. It leaves her without a support group.
So a response to indomethacin is one of the features that's typical of certain TACs. And one of the things that we noted in the survey was a couple of people shared that they had a response to indomethacin, but clearly the diagnosis had not been considered by their neurologist. So, you know, I think it again underscores the need to increase the awareness about these diseases and the understanding of the diagnostic criteria.
Thank you.
So have we got the responses into this, Andrew? Thank you. Okay, that's really interesting. I had thought that maybe there would be a preference for the wearables, but really very useful to know that the strong preference is via computer, iPad, or the phone. So thank you very much, and that was what I had to share with you on the SUNCT and the SUNA survey. And again, a huge thank you to Cluster Busters for partnering with us and doing this.
Thank you, Fiona. Thanks very much. Mark Burish responded that he agrees with you, Fiona. They've seen patients with multiple types of TACs, though it's rare. Rarely, we also see one type of TAC morph into, or TAC morph into another. And he knows people on this chat. He knows people on the chat who've mentioned that. So Mark is concurring with you. Thanks so much. We're going to move on. Oh, let's see. One moment. Just want to add this. So someone is noting that they use a migraine phone app to record, but it's not geared toward cluster. So they have they add other for every cluster. An app that with the right fields and medicines would be even better, especially if the data could help researchers. Okay, thank you.
Thank you.
All right. So next in our series of presenters is Emmanuelle Schindler. Thank you. Emmanuelle, there you are. Okay, Emmanuelle spoke yesterday, but I will, if you weren't here yesterday, I'll give you a review of her biography. Dr. Schindler is a board certified neurologist at Yale School of Medicine. She has expertise in headache medicine. She's been a steadfast researcher and longtime friend of cluster busters. She advocates for raised awareness of cluster headache, for oxygen therapy as a first-line abortive treatment, and regarding the efficacy of alternative therapies. In her work, she executed the first controlled trials investigating the effects of psilocybin cluster headache, for which we are all very grateful. Okay, Emmanuelle.
Thank you, Mark. I'm going to share my screen. Okay, so I'll give a few research updates on the clinical studies of psilocybin here. I always like to honor Dr. Andrew Sewell. Many of you here likely knew him. He was the main reason that I came to Yale in the first place, because he has been stirring up trouble with various institutions talking about studying psychedelics in cluster headache. And this cartoon, which is from more than a decade ago now, is likely Dr. Sewell talking about LSD stopping cluster headache, but the DEA is not so sure of that. But we're making some strides. As I mentioned, he was the reason I wanted to come to Yale, because he had already been planning a study looking at the effects of psilocybin in cluster headache. He unfortunately passed away right before we were able to start, but thankfully his mentor, and now my mentor, Dr. D'Souza, shown here, he agreed to go forward, and I also had was fortunate enough to have Dr. Goshak, who you heard talk just recently, also join in. This is an older picture of him with his characteristic bow tie. Dr. D'Souza, who is the PI of this study, has been studying different psychotropic medications for the past 25 years or so, including THC, ketamine, salvinorin A. So he has a lot of experience with psychotropic medications. But this was the first study that was a headache study. So it's a bit different, but we've gotten along. So it just goes to show that psychiatrists and neurologists can get along. This study has been funded by CH-TAC, which is headed by Carrie Turnbull, and the funding previously went through the Hefter Research Institute. Many of you know about that foundation, one of the only ones that are funding psychedelic research. So this study was a study that's both a Yale and VA study. So that's why I have the pictures there. So this is a pilot study. We're using the same 3-dose busting regimen that the Cluster Busters group has been discussing for quite some time, studying it in both episodic and in chronic cluster headache patients. The study is ongoing. We've completed like the first portion of it. Since it's ongoing, I can't show graphs, but I can say that we're very pleased with the results, and those results have been presented to the FDA in preparation for some future studies, and they were also pleased with the results. As I said, the study is ongoing, and we're also starting to have patients who already took part come back for a second round of treatment. This will give us a lot of information about can the effect be repeated after a second regimen? Is it safe to give more than once? So that's going to be ongoing for a little bit. So if you are interested in taking part in the study, you still can. So there's my contact information, email, phone, and my extension spells geek. So you can, that's really easy to remember. And I did not ask for that. That was just fate. And you can also search for the study on clinicaltrials.gov. And a couple of days ago, Dr. McGeaney showed how to go to the site and search. So you would search cluster headache and then psilocybin. And I see a couple of chats. Oh, thank you. Okay.
They're telling you how much they love you.
Well, I can't wait till I'm able to actually show some graphs. But right now, it's just we're very pleased with the results, and we're moving forward with it. But you can still take part in the study because we're expanding it to this longer term study.
There is a question that came through.
Yeah.
So do you think that the same mechanism that controls cluster attacks also controls shadow pain?
Insofar that shadow pain is probably going along the same tracks as the full-on cluster attack pain, I would think that maybe. In this study, we did ask people to rate, to mark down both full-on attacks and also kind of milder ones. So I can definitely look. I can separate those out and see if there's an effect on the lower ones too. Yeah, that's a great point. And what is taking part in the study involve? So first off, it's a little complicated because so many states right now need to quarantine if they come to Connecticut. So if you are in one of the states where you don't have to quarantine, this makes it easier. But or if you want to spend 2 weeks in like New York City and then come up to New Haven, that works too. But so you would receive three doses of psilocybin about 5 days apart each, but they can be given as close together as every 3 days or as far apart as every 7 days. So if you live nearby, you could just come once a week for your dose. But if you come from farther away, then you may want to come and stay, and you could get the 3 doses within about 10 days. We do have funding to help cover most travel and lodging costs. But right now, because of the pandemic, we really don't want people to have to fly or take mass transit to come here. So as the pandemic starts to become more under control, then we can loosen up those restrictions. And I have a picture here to lure you to New Haven of our mashed potato pizza, which is unlike psilocybin, is a highly addictive substance. And yes, so the ages for the study, it's age 21 to 65. So yes, there is an age limit, and this is primarily because this is the first study of psilocybin in a headache disorder. We need to just follow like the safest guidelines, and afterwards in future studies we can expand it some. Yeah. Okay, so then I can't read my slide. There we go. So in addition to the cluster headache study, I've also been doing a migraine study with psilocybin, and This one's not built the same. This was just a single dose given to patients who had migraine headache, and that very small, simple study that has been completed, and the abstract of some of the preliminary results was published in a journal, Headache, which is the keystone journal of the American Headache Society. So they clearly have an interest in this area, which is great. We're almost ready to go on a second migraine study, which is going to involve not just giving a single dose, but multiple doses, getting a little bit closer to the busting regimen that's used in cluster headache. We're just waiting the final okay from the FDA. In this first migraine study, these are the results that were published in headache in poster form. And this is just some of the findings. But here on the left, you see that after placebo, the number of migraine headache attacks per week were reduced by 1.5 after psilocybin, compared to the placebo where there was essentially no change. And this was measured over a 2-week period. So on average, every week for the 2 weeks that were measured, patients had 1.5 fewer migraine attacks. And these patients, the group started out with roughly 3 or so migraines per week. So pretty much reduced it by half after a single dose. So a single dose of psilocybin reduced migraine burden by half. And the other really interesting finding from this is that during the sessions when patients got psilocybin, it was a lowish dose, it's roughly equivalent to 1 to 1.5 grams of the dried mushrooms. So these were some of the preliminary results, so not the final results, but each one of these dots in this graph on the right is a patient, and on the y-axis is the reduction in their migraine frequency, and on the y-axis, is the reduction of their migraine frequency, and on the x-axis is how they rated their psychedelic experience during the session. So 100% of the scale is, of course, having a very psychedelic experience. So for instance, this person here had a psychedelic experience that was pretty amazing. And then they had a reduction in their migraine frequency of about 50%. But when you put it all together and look at all of the patients, there was actually no correlation with what you experienced on the test day and how your migraines were actually treated in the 2 weeks following. And if anything, it almost looks like it's actually going the other way, where people who had more of a psychedelic experience had less of a reduction. But these are small numbers that we're dealing with, and so you can't really conclude that. But it's just sort of the first snapshot to say that what you experienced during the test day has nothing to do with whether you responded or not. And this is sort of different from other ongoing psychedelic research in the psychiatric world, where the psychedelic effects are thought to be part of the treatment. For migraine, at least here, it does not seem to be part of the treatment. But of course, it could help people with anxiety or depression that comes along with having chronic migraine. So these are some of the findings that we recently reported, and we're preparing for our next study, which will be a little bit closer to the cluster headache study.
Thank you, Emmanuelle. There are some other questions that popped up
Sure.
while talking, and we have time, so
Yeah.
we're open to.
Yes, I see them.
I think the person started after, it's regarding eating, which is an issue when dosing with psilocybin. I mean, we have to watch what we eat before.
Yeah.
So I think
Yes.
that's where the questions.
So we had patients come in the morning, and we gave them a light breakfast. We asked that they not eat after midnight the night before, and this is the same in the cluster headache study too. So you don't eat the midnight of the night before. You can drink fluids and take medications that you normally do. We also don't restrict caffeine in this study because that would be cruel to restrict caffeine from headache patients. But yes, in general, and this goes for all of our other psychotropic drug studies as well, including ketamine and THC. Because nausea is a notable side effect of psilocybin, we don't want people to go to the breakfast buffet and load up on greasy food before they get psilocybin. So yes, people do have a little bit of food in their stomach when they get the drug. And so placebo, yeah. So that's the placebo is an ongoing discussion in psychedelic research world. How can you possibly blind people to the effects of psilocybin? So you can use an active control, like maybe THC. And get a similar effect. But we also know that THC can have some effects on the perception of pain or the reduction of pain itself in different headache disorders. And so we didn't want to actually use another active compound. So this study is limited by the fact that the placebo itself didn't have psychotropic effects, but there's a blinding procedure in place so that patients were not sure exactly what they got. And aside from that, when you see that how psychedelic of an experience they felt did not correlate with the therapeutic effect, then that also supports the fact that it's not just that they knew what they got. But this is an ongoing discussion in psychedelic research. It's very hard to blind. I'm going back here. We do not restrict the pizza, the mashed potato pizza for the study. Age group 21 to 65. Placebo. Both, yeah. So we actually have had patients who have both cluster and migraine in our studies. You just have to be able to separate out which is which. So yes, as long as you can distinguish the two, which most people can, you can take part. And the reduction, so we only measured out the migraine burden out to 2 weeks. This was meant as a very short-term study. And so this effect, it was seen over a 2-week period. As whether it can be sustained longer, that's part of the next study to see how long the effect can last. And there are no dumb questions here. The study using, so this is synthetic psilocybin. So this was made up in Madison, Wisconsin for us. And the goal down the line is to continue using the synthetic psilocybin at first because we have a lot of experience with it now. Many studies going back over 10 years now have been using the synthetic psilocybin, but in the future, yes, perhaps modifications from that compound can be also investigated. Every time that you tweak a molecule, make it different though, it has to go back to the beginning. You have to have animal safety studies, human safety studies, and it takes another 10 years to get it even to the first human for a therapeutic trial, or not 10 years, I'm exaggerating some, but so yes, it is possible, but that will take some additional time. Whether this means that you'll get the same effect out of a mushroom, that I'm guessing you probably get a similar effect, but I can only really speak to what I found with a synthetic substance. So for all of our studies, these talking about set and setting. So unlike the psychiatric studies where patients are in sort of like a living room, we have all of our patients, including those who are getting ketamine or THC, and it's sort of like a medical setting, like an outpatient office type setting, and we in part did that in part because the lab itself was designed like that, and we've been doing these types of studies with psychotropic drugs for the past 25 years like that, and also because there was a lot of evidence out there already that the psychedelic effects were not necessary for the treatment effects, and so we wanted to not ignore the psychedelic effects. We know that some people have them, but not to necessarily focus on them. This lab is headed up by a psychiatrist. It's on a psychiatry floor. There are always psychiatrists available 24/7 in case someone does need assistance either during or sometime after the study. So it's a pretty neutral setting, I'd say. What factors reduce the psychedelic experience? Absorption and pleasant mood. I don't know if I get, so we weren't trying to reduce the experience. Because we're using a lowish dose and that we weren't using like music and closed eyes, which are methods that are used in other psychedelic studies. We expected that the experience may not be quite as strong, but I'm not sure if I answered that question. And yes, there were people who got placebo who reported psychedelic effects, even one who reported very strong psychedelic effects. So the placebo effect can be quite strong. Does synthetic psilocybin give nausea? Yes, it can. It can. And whether it's a cleaner ride, I don't know if there's been a head-to-head comparison between the mushroom body and psilocybin that's been published, so I'm not sure. And so, are you doing a study for patients who have migraine as well? Yes, we're getting ready for the next migraine study. We just need to wait for approval from the FDA first. What's the significance of phosphorus and psilocybin as it relates to psychedelics? So the phosphate group on psilocybin, it actually gets cleaved off when it gets into your body, and it's the psilocin, which is the psilocybin minus the phosphate. That's the active compound. So the phosphate is actually needs to be cleaved off before it can actually cause the psychedelic effects. So, and this is not an uncommon phenomenon in medicine where the thing you take is the prodrug, and then the drug itself is what it gets metabolized to. And yes, we studied both chronic and episodic patients in this study, and we were pleased with the results in both groups. So. Yeah, so during the test day, we had people have a breakfast and have lunch, and so food did not impede their ability to have a therapeutic effect.
We need to conclude shortly, but
yeah, okay, yeah.
But maybe you could just quickly address the remaining questions, and then later in the day or in the lobby room, they could be elaborated on.
Okay, sure. Yeah, I'm just going to quickly go through because I think that now I can't see the top. Yeah, I'll just quickly go through since we're almost done. So those were the migraine. We're also doing a study similar to the migraine study in patients who have post-traumatic or post-concussion headache. As I work at a VA, we have a lot of patients with post-traumatic headache. This is ongoing. And if you do happen to have post-traumatic or know a patient who has post-traumatic headache, they can also reach out to me at that same number. And then I'm also planning for a series of mechanistic studies trying to understand how psilocybin works. This is going to involve neuroimaging studies, sleep studies, and also studies looking at patients' circadian rhythm, and I have many more. And I just had this picture here to demonstrate science does move very slowly, and I'm just putting a whole lot of tortoises out there trying to get to the finish line with one of these studies. So, and then future clinical trials with psilocybin. So as I mentioned, our results, they're presented to the FDA in these pre-IND meetings, and the FDA was pleased and is wanting us to go forward. So we are submitting full IND submissions for psilocybin as well as for BOL. And this effort is being headed up by Kerry Turnbull, shown there. He's the president of CH Tech, and the SUNA Institute. Many of you know SUNA Institute makes GMP psilocybin. They're manufacturing the psilocybin and putting them into capsules for these future studies. And then pharmaceutical grade BOL is also being manufactured, and we're hoping for these studies to begin, or hoping for the psilocybin study to begin in 2021. With the BOL, it might be a little longer. And I just have one quick slide about BOL, since I'm not sure if Dr. Passie was able to make it. And I talked about BOL a little bit in my talk yesterday. BOL is LSD with a bromide attached to it. And Dr. Passie was part of a group that demonstrated that 3 doses of the BOL given to here 5 cluster headache patients reduced the number of headache attacks per week down to pretty much almost 0 out to 16 weeks. So this is a BOL has greatly reduced psychotropic effects. So it's not considered a psychedelic. People felt a little bit drunk on it. So there's still a little bit of psychotropic effects, not the psychedelic effects. So the fact that the same result can be found with a non-psychedelic compound speaks to the complete distinction between the two. Okay, so that was the end there. And now I can go back and.
Thank you, Emmanuelle. I think we'll ask you to respond to those questions that remain either later today or in the lobby.
Okay.
We thank you so much for your research, and we encourage anyone who's interested in participating to reach out to you.
Yes, please do.
Thank you.